So, dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic will bring up a number of questions from you. So, you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Nilma Gupta, to start this session. Thank you, and over to you, ma'am.
So I welcome Dr. Amit, Professor and Head at the Department of ENT, AIMS Jodhpur. And over to you, Dr. Amit, for the topic on temporal bone radiology.
Thank you, ma'am. Thanks to National Board for giving me this opportunity. And when I was asked, then I was just thinking, what should I present? Then this particular topic, I see our own residents also facing. And so to start with, let me tell you, temporal bone is one of the most complicated areas of the body, and we should feel proud that we are actually dealing with it. And this is one area where no other specialty even dares to venture into or around. So neurosurgeons, they also stay out of it most of the times, and other surgeons also, they stay out of it. So this is one area which is our own baby, and nobody else can have any the mastery over it as ENT surgeon as we can have. So as with regards to radiology, the time has changed from your X-ray to CT scans, MRI, and now more complex radiological these advancements are being done. So initially, if Ms. Ma'am will also agree, we used to see the patient used to go to a CT scan center and they used to bring maybe 1, 2, 3, 4 films, and the images given were by the choice of radiologist, 5 cuts, 10 cuts, and the radiologists used to pick and choose some images, and on the basis of them, and we had our professors so learned that they used to even assess that, and they used to interpret and manage that. But when we started our practice, we found that instead of films, if we get a CD, most of the centers, I am sure they are having CD nowadays, and they are having these DICOM viewers also. So that has made the job much easier. And with the availability of multiplanar, multi-slice CT scans, the resolution is really phenomenal. We can have even 0.1 cuts if we demand for it. And previously, the patient used to get CT scan done on every plane differently. Nowadays, they just go, they have in one plane, axial plane, and they have a habit of seeing the radiology by could be heard.
Yes, sir. Please continue.
So nothing could be heard. Should I start from the very beginning, or partially it was heard?
Partially, sir.
From the beginning, Dr. Amit.
Okay, I'm sorry for this technical glitch. I hope it works fine this time. So I hope it's visible and audible as well as. So I was just discussing that the evolution of radiology, X-rays, CT scan, single slice, then multi-slice, then we have now up to 256 or maybe more than that slice available. And the biggest advantage is that the patient has to undergo CT scan only in one place. And then rest of the planes we can reconstruct. So we can have even 0.1 mm scans also available with us. So that is one advantage, and the resolution is phenomenal. So I will request all of you to develop a habit of reading the scans by yourself on a computer console or in a laptop rather than seeing the films only and reading the radiologist report. Otherwise, you will never be able to learn this art of this reading the scans of temporal bone. So we all know this just to brief anatomy so that we can correlate what we will see in the coming presentation. There is a mastoid process, squamous part, zygoma, this EAC. And then there is a glenoid cavity, styloid process, and EAC, it leads to middle ear and then inner ear. On the medial surface, what we can see this internal acoustic artery canal, that endolymphatic sac fossa, this cochlear canaliculus, and this subarcuate fossa. So I will try to show you most of the structures, this arcuate eminence and this sigmoid sinus. So I'll try to show you most of these structures. We all know the anatomy. So just remember this, what I will be trying to show you, and then we can see them on the scans, actually. So this is again the superior surface. We all can see this arcuate eminence, a very important landmark. And this is the groove for superior petrosal sinus. This is petrol FX. And this is the greater superficial petrosal nerve groove. So it leads to middle ear. So if you can imagine the anatomy, this is going into the attic area, the first genu of the facial nerve. So this is internal acoustic meatus, auditory canal, the facial nerve going like this. Then it takes a posterior turn anteriorly. It leads to the GSPM. Then middle meningeal artery groove. This is the inferior view. It's a relatively complex view. Styloid process, carotid artery, the carotid canal, and fossa for jugular foramen. Again, we can see here, this is the petrous apex. Then this is jugulocarotid this spine. So this is eroded in this your glomus jugular tumors. So again, this is jugular fossa, carotid canal, and there is a spine between them. Jugular. So again, this is the CT scan. So this is 3D reconstructed image on a CT scan. So almost the similar structures may not be 100%, but most of these things we can see again in all these views, whatever we saw on the osteology. So if we can see on these CD reconstructed images, we can see on the cuts also, and we can try to imagine the anatomy inside. Again, almost the same structures. I will not go into detail. This is dissection view. We all know that malleus, incus, the chorda tympani, the tensor tympani coming from anterior, and this is your this facial nerve. This is pyramid, and this is oval window. This is round window. So facial nerve is going over the oval window. We all know that. This is the round window niche. This is the promontory. So this anatomy we will try to see again. So normally what we ask for is sub-millimeter slices, and if you really want to, see in great depth, then maybe 0.1 mm slices will be the best for it. But normally we go for 0.5 or 0.6 mm slices, and we are able to see all the structures. So I will just show you these things, these some structures on some films. Then I will show you the actual scan after that. So this is the axial cut of CT scan. So maybe I'll go to the scan first rather than this. Let me. How to minimize it?
Click on escape, sir.
It's not working. Yeah, it's
Escape.
yeah.
Now you may open the scans.
Yeah, now you can see the scan, I hope.
Yes, we can see. Dr. Amit.
This is the CT scan. You can change the windowing by this cursor. You can convert it into soft tissue window, bone window. Radiologists also do it, but we do it on our demand. That's always better. So any this thing, temporal bone radiology, you need to ask for both. If you are going for implant or something like where the middle ear is supposed to be normal or there is no other pathology, you can ask. They usually give only soft tissue window. Otherwise, you can ask for separately. Normally, you can change the windowing by your wish, just by your cursor. And the best part is this multiplanar reconstruction. So you have to adjust it parallel to parallel and bilateral symmetrical. So once it is there, you can get away with this. You can, enlarge the image. Now we will try to see all the structures. Normally, I come from above down. This is the superior most part. So I'm coming down, just try to see both the sides, the structures. Now imagine the first structure which will come if I go axially from above down will be your arcuate eminence. And what lies below arcuate eminence is your superior semicircular canal. So I hope it is visible. We can see the dome of superior semicircular canal very clearly on both the sides. Between this dome goes the arcuate artery, subarcuate artery. So this is the passage for subarcuate artery. I hope it is visible. Then if I further go down, I will see certain structures. This going and converting into posterior canal. This is the ampulla where superior posterior canal, posterior this part they are met. This is one ampulla, and we are able to see the focus on the vestibular system only right now. This is the vestibule. This is the lateral canal. You can see the lateral canal bulge signet ring very clearly here. This is the posterior canal and going into this is the posterior canal. This is the lateral canal. I am coming up again, and this is the superior canal. So all three canals in three planes we are able to see, and one structure which is not very obvious here, but normally we are able to find a depression here, which is vestibular aqueduct. Now there are three structures in two planes. Vestibular aqueduct is always this is the internal acoustic auditory canal, and vestibular aqueduct will be perpendicular to it. So what we can see vestibular aqueduct in this direction and internal auditory canal in this direction. If I further go down, I will see another canal, this. This is the cochlear aqueduct, which will be in the direction of internal acoustic meatus only. These three structures we need to see. Sometimes there is a patent cochlear aqueduct, which may lead to, very serious this CSF gusher during implantation as soon as you open the cochlea. So one is cochlear aqueduct. Above it, superior this internal acoustic canal in the same direction, and vestibular aqueduct in the just perpendicular to it. These three things. So to see the dimension of vestibular aqueduct, it should be not more than this posterior semicircular canal diameter. So more than 1.5 millimeter is usually enlarged. So just with this structure, you can compare the vestibular aqueduct. Then again, I am coming up, I am going down. Now see the internal acoustic auditory canal. This is the internal auditory canal. Just anterior to it, you will see the cochlea. And this is the facial nerve, labyrinthine segment coming in picture. Now see, focus on the facial nerve only, cochlea we will discuss later. So you can see this. There is, this is the vestibular nerve, this is the cochlear nerve, facial nerve, sorry. Superior vestibular nerve and facial nerve. Facial nerve, anterior genome, and this is the greater superficial petrosal nerve canal. And this is the first genome, tympanic segment. Now, this is the tympanic segment coming back, and this is the facial nerve. We can see it very clearly going just anterior and inferior to the your lateral semicircular canal, and we can trace it till down, and it is exiting in the stylomastoid foramen. So again, trace it upwards, facial, facial, facial. Focus on the curve. See, this is the lateral canal, and it is just anterior and inferior to it. This is going anterior. This is tympanic segment, and here comes your first genome. So that's how we trace the facial nerve. I'll show you the dehiscence and some other situations also. Again, I'm going down. Focus on the cochlea now. The cochlea has started coming into picture. Now what we can see, the bone inside this flower. This is the modulus. So if it is present and this cribriform, this is plate is present. So that means the chances of CSF leak are less. So this is the modulus, and what we can see is the apical and middle term. And now here we can see the basal term. This is basal. I am coming up again. And this is middle and apical turn. So this flower-like structure, a clover-like structure, what you call, is the cochlea. And here what we can see is your round window niche here. So this is the cochlea. So now what structures we need to look around? I am coming up again. I am just trying to show you the structure by structure. One very important structure will be internal carotid artery. So this is not contrast picture, but still you can make the course. This is the petrous part of internal carotid artery. You can see this area. So this is your that genu where it turns up, foramen lacerum part. So from here it turns up anteriorly, the superiorly, but this is the petrous, horizontal petrous carotid artery. You can see it very clearly, and when we read, it's in the very close vicinity to the apical term. Then focus on this area. It is going down, down. See the carotid going down, down, down. This is the Eustachian tube. So what we read, Eustachian tube lies anterior to the carotid. We can see it here. Down, down, down. Now again, this is your jugular. So this is the caroticojugular crest and going down in the neck. So again, I am coming up, try to see the carotid, carotid, Eustachian tube, carotid. That was the vertical petrous, and this is the horizontal petrous part. From here, somewhere here, it turns into the paraclaval part. Now, another structure from above downwards, I'll go. Lateral sinus, and then it coming and converging into your this jugular. So lateral sinus comes from here and goes into the jugular. That's what we hear. I'll show you in different scans also and some abnormalities also. Then we'll focus on middle ear. In middle ear, we know it's the head of malleus anteriorly and head of this incus posteriorly. So we will have an ice cream cone appearance. We can see it more clearly here, where the anteriorly head of malleus is there and head of incus and short process will be posterior. So we have an ice cream cone appearance. And if we further go down, we can see the two bones. We can even try to see the stapes also. Sometimes it is very clearly see. In one scan, I'll show. I have kept it for you. So down, these two bones are there, incus and malleus. and we can see the membrane also, tympanic membrane also. So I think most of the structures we are able to see here, and if I see some of the structures, I'll try to show you in the coronal plane. Okay, in the coronal plane, I go from anterior to posterior. So the anterior most, what will come? I think yeah. This is the carotid. This is the carotid. The middle space is coming. This into carotid, 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 and now the area of jugular is coming. But what you can see here is cochlea, the tympanic membrane, the ossicle, the cochlea. You can see very beautifully this turn, and what you can see most importantly, greater superficial petrosal now, leading to first genu, leading to two dots. Now these two dots are basically the medial dot is labyrinthine segment of facial now, and the lateral dot is your tympanic segment. So you can imagine from genu, because the labyrinthine segment also turns anterior, and then it goes posterior into the form of tympanic segment. So at one place you will have both segments of facial nerve coming into picture in the coronal plane. Labyrinthine segment, if I come anterior, these will merge, and this will be the greater superficial petrosal. If I go posterior, I can see both the segments, and this segment will go into the intraopastic meatus, and this segment will continue just below the your lateral canal, horizontal canal. It is going like this, and see, we can see the vertical part of facial. I am again coming anterior. Cochlea we have seen. Now we can see all the three canals here also, superior, horizontal, and then posterior. Then I'll come anterior again. We can see the ossicles. This is the incus. This is the malleus, the first one. Then the incus, and this you can see the stapes very clearly here. IS joint and stapes. So one thing what we need to see when we are planning any mastoid surgery, the height of this segment from this horizontal canal, because in few cases this is very less. So if suppose this height is not more, then it will be a very narrow contracted mastoid. So if you operate this case from inside out technique, from outside within technique, the conventional, then you might encounter great difficulty in finding the antrum, and you may end up in intracranially rather than going into the antrum. So those cases are fit for inside out technique. So if you see the scan previously, you will always be safe. So this height and this size of the antrum, that you need to be very careful about. So that is one thing. And another thing, if you want to see, that in cases of superior semicircular canal dehiscence, how will you see? So first, you come on this plane, right? Now see. I can do many sort of things with this, and try to see the dome, complete dome of superior semicircular canal. Okay, in this picture, I will be able to see. So I have brought it in the parallel to this, and I think it is visible. The superior semicircular canal. So in dehiscent cases, there will be dehiscence here. So you can, the same thing you can reconstruct, because I have brought this marker parallel to this. So it was very clearly visible in this sagittal section. So always try to do all these things, whatever pathology you are trying to see. Now we will focus on the pathology. One more important thing for all of us to learn, that in cases of persistent stapedial artery, the middle meningeal artery is not seen. So radiologically, how will we predict it, whether it is seen or not? Middle meningeal artery normally it goes into it goes into foramen spinosum. So foramen spinosum, if we go in this sagittal, coronal section, this is the greater parrot. This is sphenoid. This is your foramen ovale, and just adjacent to it should be your foramen spinosum. I'll show you. I am able to find it. It is always, it has one nearby spine. So if this foramen is absent, then you can predict that the middle meningeal artery is not there, and it might be there in the form of persistent stapetal artery. That is a contraindication for your stapes surgery, because you will encounter heavy bleed, because that takes direct supply from great vessels. So that you have to see the presence of foramen spinosum, presence or absence, whether it is present or not. You can see it here. So I hope this much part was clear. So in the presentation again, this same pathology, then I will show you some more scans quickly. So here what we can see here is, all those structures which we were trying to see, the cochlear aqueduct, the basal turn, then the ossicles, the modulus is there. Okay, then there could be some, sinus tympani, we can see very clearly whether it is shallow, type A, type B, or type C, very deep. So this will help us in clearing the cholesteatoma, because this is one part where cholesteatoma usually is not cleared. So if it is a type C, then you really need to work harder to clear the cholesteatomas. Then maybe I'll skip this part because I want to show you some scans in the remaining 15 minutes. So this facial now, as we have already seen, you can see it very clearly, the genu and horizontal part. Again, intracoustic matrix, we can see whether it is widened or not. Average is 4 millimeter. Then you can see this vestibular aqueduct. So in this case, it seems quite widened here. And we can see this lamina also. If it is dehiscent, then you have to be careful again. Ossicle, this ice cream cone appearance I was talking about. The head of malleus and head and short process of incus. It's very clearly seen, and normally it's an hourglass thing. The epitympanum, the mastodentrum, and relatively narrower editus part where it is there. Then we can see the ligaments also. This anterior malleolar ligament is very clearly seen here. So then again here we can see these ligaments, and we can see the stapedius tendon also very clearly on CT scan. So disease wise, if I show you some pathologies. Before that, just one word about this, MRI. In MRI, this cholesteatoma, nowadays relook surgery has been largely replaced in Western world for intact canal wall mastectomies by MRI. If you go for diffusion weighted sequences, it can very categorically tell you whether cholesteatoma is there or not, recurrent cholesteatoma. And you can see the nerve complexes also, internal auditory canal also you can assess, and CP angle also. So just to see a few scans, this diffusion images, it can show intense restriction on diffusion on MRI. Or diffusion weighted images. So this is a pathognomic of your cholesteatoma or epidermoid. This intense restriction, it will appear very bright. And if you adjust the this adjusted image, it will go black. So in ADC adjusted this diffusion coefficient, it will go black. Otherwise, on diffusion, routine diffusion, it will appear bright. So that, if you remember, it will be a pathognomic of cholesteatoma or epidermoid. So our relook surgeries have largely been replaced by MRI in intact canal wall mastectomies. For interlocustic matrix, we can see this 4-dot appearance, telling us that all 4 components, these nerves are present, components of the nerves are present. And this I will show you in just some time. So I'll show you few scans. Let's start. One, I will show you this aberrant artery, intellect carotid artery. So if you see it, it's very interesting to see. Just see, try to see. And such cases are nightmare. If you don't pay attention, you will always, you see the internal carotid artery, how close it is to the cochlea. And it's almost in the middle hypotympanum. The ICA is in the hypotympanum, just below the cochlea, and coming inferior part of the cochlea is actually covered by this. So this is your cochleostomy site. So if you go even half a millimeter beyond, you are liable to injure it. This case was successfully implanted, but this was actually, we could see this, otherwise it can land up in a serious trouble at some times. So what we can see here, if you see this scan cornel, you will realize what I am trying to say. See, this is your ICA and this is your cochlea in hypotympanum. This is a very scary situation. Then the next pathology what we will discuss will be, we'll see is this lobby. Yeah. Okay. It's also a very interesting case. The child has profound hearing loss, both sides cochlear anomalies, but he presented to neurosurgery department with CSF rhinorrhea. And just by history came to know that child did not respond to loud sounds. We got the scans done. This is actually post-op scan for left side. We did the CSF leak repair and cul-de-sac. And the pre-op scans, which unfortunately I could not get it today. On MRI, always remember this T2 sequences. T2, the CSF will appear bright, white. So T2 H2O white color, you can remember the mnemonic. And this white color is actually this fluid intensity it is telling us. So all black is bone. And this is fat actually. So you can get this in pre-op scans, this anomaly, there was a leak in the middle ear. And this is a post-op scan where we did second repair of leak. So both sides you can see the cochleovestibular anomaly is there. The cochlea is not developed. You won't be able to see the clear structures. These all the three things. He was having this 1.5 ton only on the right side, on which side it was implanted. And the vestibule was, we can't see the vestibule here on the left side. If you see, it was all malformed. And these images are seen used as non-contrast MR cysternography in the cases of leak, even in CSF rhinorrhea cases also, and CSF otorrhea cases also. If you want to see the site of leak, these images are very much helpful because this white color trail will be very clearly visible in such images. The leak site will be very clearly imaged. Then I will show you this enlarged vestibular aqueduct. Okay, now you can see here this vestibular aqueduct. I was telling you, this is your internal acoustic canal, this is your vestibular aqueduct, and we can see the diameter is much more than your posterior canal. So this is a clear-cut case, and such cases, they don't present with normally, CSF leak during implantation, but they may have this pulse. When you open the cochlea, then you will see intense pulsations in those cases inside. Then one case of facial nerve dehiscence, I'll try to show you. Again, trace from above downwards. This is internal acoustic canal. We can see the labyrinthine segment. Here you can see the labyrinthine and intact, but as it goes to the genu part, the second genu, you see there is no bone here. So the second genu is actually exposed in the disease. Then after that, you will find again it going into the stylomastoid foramen. So this part is actually dehiscent, the genu part in the facial nerve. It's a case of cholesteatoma. You can see the ossicular erosion and this soft tissue density there. Then one case of labyrinthine ossificans, maybe we can see. Okay, this is scan. You see there is absolutely no your cochlear lumen you can see. It's a post-lingual case, post-meningitis, and first we'll see on the right side. Absolutely, this dense bone is there. Nothing you can see, no trace, except this basal turn, very minimal. And if you want to measure it, you can use this measuring tool. And what you can see it hardly, just 4 mm. 4 mm lumen you can see it, that also not completely wide. It is also narrowed lumen. It's not as wide as it should be. And on this side, left side, absolutely not even this much. Only a shadow of lumen you can see. So this is a case of complete labyrinthine ossificans post-meningitis. We can see some difference in the otic capsule bone and this ossificans bone. The density is different, but this is entirely filled by, this bone. So this patient was, a very tough case, and just few electrodes could be passed on. We'll see this lateral semicircular canal dehiscence. Yeah. This is an interesting case, and I will show you one more interesting thing to learn. First, I'll show you the canal dehiscence. You can see it here. You can see that the canal is eroded. The signet is not complete. It's eroded here with the disease. And if you see the, coronal image of this same picture, what you will see is actually the brain was, and there was a defect in the tegment. It was a previously operated case of, cholesteatoma metastasis. There was a huge defect in the tegment, and there was a herniation. Whenever you see such case, post-operative case, or even so, if you see a tegment defect, always prescribe an MRI. And why you need an MRI, that I'll show you just now. Because of this thing, you can see this brain, continuation of brain getting herniated here. So whenever you see a tegment defect, post-operated case, do not put your hands in without an MRI. In private setup, it may cost a bit, but it will save you from many other problems. Now, another case I'll show you, very interesting case. It doesn't have much of the, it doesn't have much clinical relevance, but at least it's always good to see this thing. Just see superior canal, this is posterior canal, and see the posterior canal is dehiscent here at one point. So this also you should always try to see all the canals. It was a very interesting finding, in fact. Then again, another case, maybe this one, a case of herniation. Post-operated case again. And oh, I'm sorry. So I'll just continue with this thing, and I think I'll stop here. Any questions? Navneet or Dr. Nilima?
Yes, Dr. Amit. I think there are a couple of questions in the chat box. Can you open the...
Ma'am, I have opened it, but I can't find any question. I hope the connectivity was okay in the last later on.
Lost it for a few seconds in between. But otherwise, the slides were visible throughout.
Okay.
Yeah. So there were a couple of very interesting points that you mentioned. The labyrinthine segment and the tympanic segment seen together, and enlarged vestibular aqueduct and the herniation. Very nice presentation. Mr. Navneet, can we have the questions? Can you, because even I am not able to see the questions in the.
Navneet, are you there? I think there are no questions.
I'm also checking.
Yeah. Okay, ma'am. Somebody has asked just now. So I will see. Dr. Ramendra Kumar Singh is asking, what is the best way to learn this topic? So I will say that the best way to learn this topic is always read it yourself and then correlate with the radiologist, uh, his reports. It will not be a one-day job, definitely, but maybe you can spend 3 to 4 hours on one scan only, normal scan, one day, and try to see all the whatever we have seen. Read the anatomy, try to see all the things, and there are books also available. But books will only help when you will see the scans by yourself. They won't help. If you read the books only, they won't help. So unless you develop this habit of seeing the scans yourself and spend time with the scans, initially half an hour you might be clueless what to see. Then again, recall the anatomy. Learn to get the right window, learn to get the right plane. Because many times what happens that you get the distorted plane. Right side you might be seeing the cochlear part and left side you might be seeing the, maybe PNS or greater wing of sphenoid. That skew these pictures won't give you a means clear understanding. So always try to adjust them, learn to adjust them in the correct plane, correct windowing, and then try to see structure by structure. Focus, maybe one day you can just see the facial now. Then one day only on the cochlear, one day only on the ossicles. Then only gradually you will be able to have mastery. If you read this, if you see the films only and read the radiologist report, you will never be able to.
So, Dr. Amit, I had a question that these days, though most of the places the CT scan facility is available, but supposing you are working in a setup where CT scan is not readily available. So,
Right.
in your mind, what could be the kind of absolute indications for getting a temporal bone CT scan, without which you would not kind of venture for the surgery?
Ma'am, then I think we are talking about cholesteatoma surgery.
Yes.
That's the commonest thing where we require. So, ma'am, there are in our department also we have a intense debate on this thing. So, I prefer CT scan in almost all the cases, and without CT scan, I always, it's not that we cannot operate, but if it is available, we should operate. Number one. Number two, if it is not available, then certainly if you are, expecting a complicated case, some impending complication, then it is always advisable to get one, because complication, a patient comes to you with headache or maybe with some delirium. You really don't know what you are dealing with. You have a large segment defect, or you have brain abscess, or just is in the meningitic phase, or so at least those things will help. Those are probably the absolute indications. And in these days of litigation, especially, and when with the availability of CT scan, personally, I get it done in my all the cases. But in our department, we have faculty who don't get it done routinely. So that personal thing is always there. But in today's this training thing, I think it should be getting done. And if it is not available, then certainly the complicated cases you will not put your hands without CT scan, where you are expecting a even slightest complication. Even if there is a case of sensorineural hearing loss in cholesteatoma, so
Yes.
it is already involved. You don't know what place the fistula is there or what place is eroded. And frankly, we have seen, means you must have also seen the extensive cholesteatoma cases where the entire aortic capsule came out as a single piece of bone, rock. It was a rocking aortic capsule I'm talking about, the entire cochlea. So we may encounter such cases also, and where no landmark is available, the facial is entirely exposed within the lesion itself. In fact, we have seen cases where we could pass on the cotton ball all around the facial now in the vestibular part. Entire vestibule was eaten up. So complicated case without CT scan will still be a not to do things sort of. But routine cholesteatoma, if you think, okay, it's a conductive hearing loss, so in that case, preferably go inside out, because again, you don't know how big is the mastoid, what is the condition of other tegmen and other things. So inside out is a better way to go if you are operating without CT scan. But again, inside out takes a bit more technical, expertise. So
Yeah, so we can agree that in CSOM cases where there is an impending complication, or a patient who has presented with a complication, such as a
yes.
facial paralysis, any intracranial complication, vertigo, giddiness, feature bronchitis. So a patient who has presented with these complications, maybe a post-oral fistula or even an extratemporal abscess. Then
Exactly.
in vision, MRM, you would definitely like to have a CT scan.
Yes,
Case
revision number, exactly.
ear, like the patient has come for surgery to the only hearing ear, the other ear is already dead or has a severe sensorineural hearing loss. Again, you would like to go for a CT scan. So
Right.
these would be the absolute indications. For a primary case of cholesteatoma in an adult, maybe if it is not readily available, we can forego the CT scan. But these days, with the additional information, you can decide upon the approach, you can be better equipped at the time of surgery. So we are also getting CT scan in most of the cases. But sometimes, as an emergency
Yes.
situation, we might have to open up a patient without a CT scan.
Right.
Okay. And if seeing the CT scan on a console facility is not available, then what would be the cuts that you would request, and which you will consider sufficient for a case of CSOM
Right, ma'am.
adequate?
So the thing is, there are two aspects of it. One is that console means you have laptop and free DICOM viewers. So you just need to ask for a CD. The problem occurs in private setup if they get thicker cuts, maybe 3 or 5 slices. So that you have to convey to them that you need finer cuts and in CD with the DICOM files. Suppose if you don't have those cuts, then certainly in all the three planes, in all the
Yes.
three planes, and in both soft tissue and bone window, that should be the minimum requirement.
Okay. Okay. So soft tissue windows, bone windows, then cuts in all the planes,
Yes.
preferably 1 mm cuts in the facial nerve region, and otherwise the 3 mm cuts if they are available. Then in most of the cases you are good to go, because there are many of the times they just come with the film or they come with a CT scan, and
So what
that
happens normally, this sagittal plane is normally very, less red plane sort of, or less asked for. So when you will see more and more scans, you will actually, especially in extensive cases, the sagittal planes, they are very useful. So that sagittal plane is still, we may say, okay, that is the last one to be asked for probably in the beginning. But when you see more and more cases, you will automatically start asking for that also.
Yes, and what would be the indications of getting an MRI temporal bone?
MRI indication is certainly if suppose in cholesteatoma cases I will talk about, because rest there are indications like glomus tumor are there, or some malignancies there. So
Yes.
skull-based involvement, there MRI is a must. In cholesteatoma cases, MRI intracranial complication is the commonest indication, where you expect some dural involvement or brain abscess. There we do get it done. They are not absolute indications, but if it is available, we always prefer to get it done. That gives some additional information about the brain parenchyma, but they are not absolute thing. Nowadays, there are studies going on for facial nerve codes by diffusion tensor imaging thing also, but they are also not yet clinically validated. So once that comes, probably that may become another indication for getting an MR done, especially in cases of facial nerve palsy, even in cholesteatoma cases. That can be one.
Yes, yes. Yeah, so Mr. Navneet, are there any questions in the chat box? Otherwise, then we can close the topic.
You're not audible.
Excellent presentation, Dr. Amit Goyal. Thank you very much for this presentation. And thank you very much, Dr. Nilima Gupta, for joining us. And thank you, trainees, for joining us.
Thank you. Thank you.
Dr. Amit, thanks a lot.
Thank you.